Sir, good morning, sir.
Good morning, Andrea.
Sir, na voice okay na? Okay.
మొదలు పెట్టమ్మా. వర్షం వస్తుందని ఎవరు రాలేదు? శ్రీకాంత్ రాలేదా?
గుడ్ మార్నింగ్ సార్.
శ్రీకాంత్ మొదలు పెట్టచ్చు కదా. 10 మంది వచ్చినట్టున్నారు.
ఓకే సార్.
మీ దగ్గర ఎన్ని అవుతాయి శ్రీకాంత్?
సార్ ముందు ఒక 10 అలా అయ్యా సార్. ఇప్పుడు తగ్గాయి సార్. అంటే ఆవిడ సునీత మేడం వెళ్ళిపోయారు కదా, సో ఇప్పుడు కొంచెం తగ్గాయి సార్. అప్పుడు బాగానే అయ్యేవి 10 to 15 అలాగా. ఇప్పుడు 4, 5 అలా అవుతున్నట్టుంది. కొత్త ఆవిడ.
మీ దగ్గర ఎంత అవుతాయి రామప్రసాద్ గారు? రామప్రసాద్ గారు,
హలో సార్, గుడ్ మార్నింగ్ సార్.
Left hypertension.
బాగా.
Good morning to all. Good morning, Shrikant. Good morning, Ravan Prasad sir.
గుడ్ మార్నింగ్ మేడం.
మార్నింగ్ మేడం.
Good morning to all. Sir, నా వాయిస్ వినబడుతుందా?
వినిపిస్తుంది మేడం.
ఓకే. Can I start, sir?
ఇప్పుడు శ్రీకాంత్ స్టార్ట్ చేయమని.
ఎస్ సార్. మా వర్షంలో మా అమ్మాయిలను దింపడం, స్కూల్కి దింపడం హడావిడిలో ఉన్నాను సార్. ఈ వర్షం గొప్ప పడుతుంది.
చాలా ఎక్కువ
సార్. కార్ లోనే ఉన్నాను సార్. పర్లేదు, స్టార్ట్ చేస్తాను.
ఓకే, థ్యాంక్ యూ. ఎందుకంటే నాకు 9 కేసు ఉంది.
Another doesn't need any introduction. Please start.
Okay. Good morning to all. Today my topic is anesthesia for cesarean delivery. So going to the introduction, cesarean delivery is defined as the birth of a baby through incision in the abdomen and uterus. Going to the indications for cesarean delivery is maybe maternal cause, fetal cause, and obstetrician. Fetal cause like breech presentation, malpresentation, fetal intolerance of labor, suspected macrosomia, non-reassuring the fetal status, prolapsed umbilical cord. Maternal cause like antepartum and intrapartum hemorrhage, arrest of labor, breech presentation, deterioration of maternal conditions, dystocia, failure of induction of labor, and genital herpes, high order multiple gestations, twin gestations when twin breech presentation, maternal request, placenta previa, apraxia, myomectomy, previous myomectomy, prior classic uterine incision, uterine rupture. Going to the pre-anesthetic evaluation, we have to focus the pre-anesthetic history, patient's detailed history of medical history, surgical history, and anesthetic and obstetric history, indication of cesarean delivery, and the presence of labor or an absence of labor, urgency of cesarean delivery, and available of resources at the situation. Going to the physical examination, baseline BP and heart rate, airway, heart and lung examination we have to see, and with we have to follow the ASA guidelines. Appropriate indicated investigations we have to choose, and take informed consent. Other preparations like blood products, risk factors, and baseline hematocrit, blood group and type screen, cross-matching, and equipment of rapid and availability of monitoring SpO2, ECG, NIBP, fetal heart rate monitoring, urine output, sometimes EEG, BIS, invasive monitoring, some cases. Availability of equipment, anesthesia, airway management, availability of medication, in general anesthesia, neuro excel block, vasopressors, obstetric like uterotonic agents, emergency ACLS, and malignant hyperparexia. So cesarean delivery is an increased risk of pulmonary aspiration because incompetence of lower esophageal sphincter, distortion of gastric and pyloric anatomy, decreased barrier pressure, decreased gastric pH, increase the gastroesophageal reflex, and increase the intra-abdominal pressure. Take a history of fasting. So elective cesarean delivery, 6 to 8 hours on nil per oral, allow clear liquids up to 2 hours. Emergency cesarean delivery, ingestion of solid foods should be avoided in the laboring patients. Comorbid conditions like morbid obesity, diabetes mellitus, difficult airway may warrant longer fasting times. Once in labor, we have to delayed gastric emptying are at high risk of aspiration during general anesthesia. Aspiration prophylaxis like H2 antagonists reduce the gastric acid secretions like ranitidine. In the elective cesarean section, you have to give 150 mg orally 60 minutes prior to surgery. Emergency cesarean section, 50 mg IV more than 30 to 40 minutes prior to surgery. Metoclopramide is a chromatherapy agent, hastens gastric empty, increases low esophageal sphincter tone, decreases nausea and vomiting. 10 mg IV more than 30 minutes before induction. Antacids to raise the pH of gastric contents. You have to take non-particulate antacids like sodium citrate 30 ml given 30 minutes prior to surgery. So gastric pH is more than 6 hours per. So pH more than 6 per 1 hour. Going to the monitoring, we have to follow the ASA standard basic monitoring. maternal pulse oximeter, SpO2, ECG, NIBP, fetal heart rate monitoring like before and after administration of anesthesia, urine output, plus or minus depth of anesthesia monitoring, IV access like a 16 or 18 gauge, and balance of salt solutions such as ringal lactate. Supplemental medications like benzodiazepines, even low doses we can use. It is no neonatal effects. Amnesia, typical avoided during the week's cesarean delivery, may be given in women with severe anxiety, emergency cesarean delivery. Facilitate performance of a neuraxial technique, awake tracheal intubation, or the induction of general anesthesia. May mitigate the feelings of distress during childbirth. Risk for developing post-traumatic stress disorder. Going to the positioning, aortocaval compression by gravity uterus is supine hypotension syndrome, pallor, tachycardia, sweating, nausea, hypotension, and dizziness. Compression of aorta and common iliac vessels, decreased venous return, decreased cardiac output, increased uterine venous pressure that reduce the uterine placental blood flow. More than 20 weeks of gestation, you have to follow the 15 degrees of left lateral tilt, left uterine displacement, and after neuraxial and general anesthesia delivery of the baby. Supplemental oxygen, like maternal administration of high FiO2 is recommended during emergency cesarean delivery of a compromised fetus. Routine oxygen administration during elective cesarean delivery may be unnecessary and ineffective and may even be detrimental. Preterm fetus is non-laboring mothers are highest risk for hyperoxia-induced injury. Anesthesia techniques for cesarean delivery, it depends upon maternal, fetal, obstetric factors. You can go for single shot spinal anesthesia, epidural anesthesia, and combined spinal epidural anesthesia, continuous spinal anesthesia, extension of epidural labor analgesia, general anesthesia, and local analgesia. So neuraxial techniques in increasing use, growing use of epidural techniques for labor analgesia, recognizing that placement of epidural catheter, even if not used during labor, may decrease the need for general anesthesia in an urgent situation. Airway complications associated with general anesthesia, less fetal drug exposure, contraindication general anesthesia like malignant hyperparaxia, pulmonary disease, and GA intolerance or GA failure. Mother is awake to experience childbirth and support person can be present. Improvement in quality of neuraxial anesthesia along with adjuvants, postoperative neuraxial analgesia, reduced blood loss and shivering, reduced risk of DVT, better recovery, less pain, less GIT stasis, less coughing, less fever, less depression, able to breastfeed and ambulate and more quickly and avoid the DVT. Adequate extent and density of neuraxial blockage, prevention or treatment of hypotension, maternal anxiety, fear of pain and surgery, more chance of intravascular injection in pregnancy, reduced dose of local anesthesia required. There is a decrease in therapeutic dose and toxin plasma levels of local anesthesia. These are the concerns of neuraxial anesthesia. So adequate neural blockage for CD, adequate sensory level of anesthesia to minimize the maternal pain, avoid urgent need for general anesthesia. Goal for CD, sensory block for sacral dermatomes to T4, T6 blockage to absence of touch, complete absence of hip flexion, ankle dorsiflexion, and under surface of diaphragm C3 to C5 and the vagus nerve may be stimulated by surgical manipulation. Maternal discomfort, shoulder pain, nausea, vomiting, despite T4 level of blockage, may be elevated by neuraxial systemic opioids. How to prevent the hypotension? It is a common sequelae of neuraxial anesthesia. SBP more than 20 to 30% from baseline or SBP less than 100 mmHg. So going for intravenous fluids, crystalloids and colloids, 10 to 15 ml per kg. Healthy patient approximately 1 liter crystalloid loaded and starting at the time initiation of neuraxial anesthesia. And a high risk of hypotension, consequences of hypotension can be colloid. Vasopressors, you can use ephedrine, phenylephrine or norepinephrine. Phenylephrine bolus is 100 to 150 mics bolus and followed by infusion. Physical methods of left lateral compression bandage, lower limb compression bandage, pneumatic compression devices, lower dose of spinal and local anesthesia, and the combined spinal epidural. Treatment of hypotension. Vasopressor should be administered as soon as BP begins to decrease, rather than occurrence of clinically significant hypotension. Maintain BP more than 90%. According to NICE guidelines, you can use phenylephrine, ephedrine, or equal effect of vasopressor, but get fetal acidosis with use of ephedrine. IV bolus is 5 to 10 mg, phenylephrine 50 to 100 mics, and continuing infusion 25 to 50 mics per minute. So when you're going for single shot spinal, its positive effect is typically simple, rapid onset, dense anesthesia, low drug doses, no risk of maternal loss, and a minimal fetal drug transfer, predictable and prompt recovery. So going to the negative point, limited duration of anesthesia, limited ability to titrate extent of sensory blockage. In continuous spinal anesthesia, it is the positive points like low drug doses, rapid onset of dense anesthesia, ability to titrate extents of sensory blockage, continuous intraoperative anesthesia. Negative points like large dural puncture, increased risk of PDPH, possibility of overdose, and total spinal anesthesia if the spinal catheter is mistaken for an epidural catheter. So what are the drugs in for spinal anesthesia? Bupivacaine is we are using 4.5 to 15 mg, in single shot spinal 10 to 15 mg. In pregnant patients, it gets smaller doses, smaller CSF volume, more capillary movement of hyperbaric local anesthesia, and supine pregnant patient, greater sensitivity of nerve fibers, and lower CSF gravity. We can use adjuvants, improve quality of intraoperative anesthesia, prolonged postoperative analgesia, reduce dose in spinal and epidural adjuvants like opioids, fentanyl, morphine, dextrose to make hyperbaric, alpha-adrenergic epinephrine, and the neostigmine. So epidural anesthesia, use of in situ catheter placed earlier labor for analgesia for non-elective cases, no dural puncture, slower sympathetic blockage, titrate sensory blockage, continuous intraoperative anesthesia, and postoperative analgesia for positive points. Going to the negative point, slow onset of anesthesia, less reliable block, larger drug doses, greater risk of maternal loss, greater fetal drug exposure. Combined spinal epidural anesthesia may be technically easier than spinal in and spinal in obese, lower drug doses, rapid onset, dense anesthesia, able to titrate extents of sensory blockage, continuous intraoperative anesthesia, continuous postoperative analgesia, useful technique where surgical duration expected to be prolonged. Negative point is delayed verification of functioning of epidural catheter. Going to the drugs, 2% lidocaine with epinephrine, slow onset, risk of severe sequelae from unintentional intravascular injection, systemic absorption. Ropivacaine 0.5 to 0.75%, levobupivacaine 0.5%. Adjuvants like fentanyl, suventanyl, hydromorphine, meperidine, and sodium bicarbonate. Indications for general anesthesia, maternal refusal, failure to cooperate, contraindication for neuraxial technique, insufficient time, failure of neuraxial technique, fetal issues, cesarean delivery as part of planned ex utero intrapartum treatment, exit procedure, consents for general anesthesia, implications of physiological changes in pregnancy, prevent aspiration, supine hypotension, airway management, adequate maternal and fetal oxygenation, appropriate depth of anesthesia, prevent anesthesia associated uterine atony, minimize adverse effects on neonate, induction and incision delivery intervals. Going to the pre-anesthetic evaluation, we have to assessment of physical characteristics, airway and comorbidities. Consent process should feature risk of airway management, aspiration, awareness. Airway suggests difficult intubation, plan for awake intubation, difficult airway intubation, difficult airway cut and video laryngoscopy, aspiration prophylaxis, arrange blood and blood products. Induction of general anesthesia, maintain left uterine displacement in OT table, prevention of aortocaval compression, IV access and monitoring, abdomen prepared and draped, verify that surgeon is ready to begin. So you can minimize induction of delivery time. Dehydrogenation, pre-oxygenation, 100% oxygen for 3 minutes, tidal breathing, at 4 to 8 vital capacity of breaths. Go for the rapid sequence induction with cricoid pressure. You can use a cuffed endotracheal tubes, prepare a small endotracheal loop, undersized endotracheal tubes like 6 and 6.5. Anesthesia drugs, IV induction is faster in pregnancy because the high cardiac output, decrease serum albumin, decrease protein binding, larger fraction unbound drug, enhance drug effect. IV induction agents like thiopentol, propofol, ketamine, etomidate. Neuromuscular block is succinylcholine, decrease the plasma cholinesterase, but also increase the volume distribution, dose unchanged. Duration of block with scoline same or decrease. Non-depot muscle relaxant, when scoline is contraindicated, you can use rocuronium 1 mg per kg. Going to the airway management, it is very careful airway assessment. Weight gain, increased soft tissue neck, breast engorgement is difficult to bag mask ventilation and difficulty laryngoscopy. Capillary enlargement of respiratory mucosa and increased edema of vocal cords can easily traumatize the endotracheal tube and NG tube. Bleeding and trauma, difficult intubation, keep smaller size ETT and always keep a difficult airway cut. So delivery of baby, during confirm the correct placement of ETT and maternal ventilation, oxygen and nitrous approx and MAC 1.0 MAC volatile hallucinated agents, high FiO2 if fetal compromise. In the absence of or fetal compromise, FiO2 guided by SpO2. Nitrous oxide has minimal effects on maternal BP and uterine tone, allows for reduction in concentration of the volatile agent. Maintain normocapnia of pregnancy, PaCO to 30 to 32 mmHg. Treat any hypotension, use phenylephrine and ephedrine. Maintenance of anesthesia, observe the delivery of infant, baby, bolus, and or continuous infusion of oxytocin. If uterine tone is inadequate, consider other uterotonic agents, methyl ergonovin, methyl prostaglandin, and misoprostol. Monitor blood loss response as necessary. Adjust maintenance techniques after delivery. Reduce the concentration of volatiles 0.5 to 0.75. Supplement anesthesia nitrous and IV opioids. Give attention to risk of awareness and recall. Consider administration of Medigolo. Anesthesia requirements for volatile hallucinated agents diminish 25 to 40% during pregnancy. Produce dose-dependent CNS CVS effects. Decrease in BP because of decreased uterine blood flow and decreased uterine tone. Dose-dependent uterine relaxation more than 0.5% MAC. Antidal levels of hallucinated agents 1 to 1.5 MAC may reduce the effect of oxytocin on uterine tone and greater blood loss after delivery. After extubation, we have to keep the semi-recumbent position. Patient demonstrates purposefully response to verbal commands. Written or protective airway reflexes. If repeated airway manipulations, massive hemorrhage, emergency hysterectomy has occurred, delayed extubation and transfer ICU. Local anesthesia for cesarean delivery, usually supplemented for inadequate neuraxial anesthesia, can facilitate emergency CD in absence of anesthesia provider, rarely provides the satisfactory anesthesia as a primary technique. Going to the postoperative care, it is a periodic assessment. See the airway patency, respiratory rate and saturation, adequate postoperative analgesia. After neuraxial block, epidural intratracheal opioids, plus or minus local anesthesia, or plus or minus systemic analgesia. After general anesthesia, go for systemic analgesia with the paracetamol, NSAIDs, opioids, and PCA. Early oral consent within 4 to 8 hours, shorter time to return the bowel sounds, and shorter hospital stay, and early mobility and ambulation. Complications of the CD, awareness and recall, thoracic proprioception, increase the partial blockage of abdominal and intercostal muscles. Pressure of abdominal contents again is the diaphragm in recombinant position, and decrease loss of ability to vocalize, poor hand grip, SpO2, high spinal anesthesia, you go, emergency rapid sequence in intubation of general anesthesia. Sir, my voice okay?
Okay, Anuradha, it is well heard.
Okay, because my net issue.
Yeah, I think everywhere
Other
there is a problem.
Okay. Other complications like hypotension, failure of neuraxial blockage, high neuraxial blockage, unintentional intrathecal or subdural administration of epidural dose of local anesthesia, nausea and vomiting, and perioperative pain, pruritus, hypothermia, and shivering, PDPH. So today is a nutshell of the cesarean delivery. CD is the commonest major surgical procedure performed in most countries. Neuraxial anesthesia has definite advantages over general anesthesia. Skills of anesthesiologists is giving general anesthesia for CD are diminishing. General anesthesia in a pregnant woman is associated with a higher risk of difficult airway and awareness when compared with the non-obstetric population. Neuraxial anesthesia is preferable to general anesthesia for cesarean delivery as it is associated with less maternal, neonatal morbidity and mortality. Small gauge pencil point spinal leads 25 gauge smaller are less likely to cause post-puncture headache. Prophylactic measures to avoid spinal-induced hypotension are important to maintain uteroplacental perfusion. We can use phenylephrine infusion. Oxytocin is recommended with initial bolus doses 1 to 3, 1 international units intravenously, followed by infusion. The addition of neuraxial opioids improve the quality of intraoperative block and postoperative analgesia. So it is cesarean delivery is you can divide the 4 categories. One is emergency cesarean delivery, urgent cesarean delivery, and scheduled delivery and elective. Emergency means immediate threat to life of the woman or fetus. It is recommended 30 minutes. So acute fetal distress, fetal bradycardia, cord prolapse with bradycardia, suspected scar descent, uterine rupture, antepartum hemorrhage with hypovolemia, failed instrumented delivery. So urgent cesarean delivery means maternal or fetal compromise, not immediately life-threatening, recommended 75 minutes, cord prolapse with a normal fetal heart rate, malposition in labor, antepartum hemorrhage without hypovolemia. Scheduled cesarean delivery, no maternal fetal compromise but needs early delivery. Failure to progress with no evidence of maternal and fetal compromise. Early labor in a woman scheduled for an elective cesarean delivery, large for gestational age or breech presentation, failed induction of labor, preeclampsia at term, unsuitable for vaginal birth, any other indication determined by the obstetrician. Elective cesarean delivery time to suit women and staff, and planned elective cesarean delivery. So advantage of neuraxial and general. In a neuraxial, awake patient who can participate the experience of childbirth with the presence of partner and support person, able to perform early skin to skin, breastfeeding which improve bonding, and effective post-operative analgesia. We are going for general anesthesia because of rapid provision of anesthesia for emergency surgery, no pruritus, no PDPH, no neuraxial neurological complications. So disadvantage, cardiovascular instability, pruritus, PDPH, slow onset in neuraxial. In general disadvantage, patient unstable to participate in childbirth, greater maternal morbidity, airway problems. I don't know abbreviation of AAGA. And greater neonatal morbidity, lower upper and umbilical venous pH, increased requirement post-operative analgesia and opioids and tab block. So these are the referral articles. In these articles is a compared to study of neuroaxial in general, but statistically it is no difference between the neonatal ICU admission, length of stay. It is emergency cesarean or elective cases. But in second point is APGAR score is higher in spinal compared to general anesthesia. And in spinal elective cases, more use of diclofenac, paracetamol, and more in regional compared to general anesthesia. And the people are very satisfied epidural anesthesia. These are the studies done, comparative studies. Thank you so much for listening this topic. So everyone experts in cesarean delivery and giving anesthesia and everything. So this is the only just refresh topic only. Thank you for listening.
I think you have a less experience compared to other people, so other people can contribute more. I'm sure when you are PG, you would have done much better, but now because the cases, number of cases, what you're doing more into cardiac, so maybe you have a high risk cases experience.
So more experience in Srikanth sir and Mehtaji, Ravana Prasad sir.
Good morning, madam.
Good
How
morning,
many
sir.
times do you do antenatal scan, and what are the names of that antenatal scan?
Sir, mere cheppandi sir, I don't know.
NT scan, neural translucency scan. It is usually done around 11th week to know the development of the spine of the fetus. Next, TIFA scan, targeted immunology for fetal abnormalities. It is done around 18 to 20 weeks. Next,
Okay,
growth scan to know the fetal position and fetal weight. It is done around 28 to 30 weeks.
Thank you, sir.
Madam, what is the average blood loss in cesarean?
Average, sir.
These questions are for DNB students, not for you, madam.
But I'm also thinking, sir.
Yeah, average blood loss in a vaginal delivery is 250 ml, and in cesarean section it is 500 ml. Madam, sensory loss T4 వరకు వస్తే పేషెంట్ breathless అవుతారు. నాకు ఆ డౌట్ ఉంది. Most of the books says sensory loss should be up to T4.
T6 లాస్ టచ్ సెన్సేషన్ కొంచెం T4 వరకు మెయింటైన్ చేయమన్నారు.
And most of the times when sensory loss
T4 వరకు రాకపోతే when there is peritoneal pull, patient feels very అది epigastric pain లాగా చెప్తారు సార్. when there were initially when I have joined PG, నాకు అర్థమయ్యేది కదా. I used to think maybe అది epigastric అంటే ప్యాంటాప్ ఇస్తే సరిపోతుందేమో అట్లా అనుకునేదాన్ని. but later I understood T4 వరకు వస్తేనే the last లో peritoneal pull కి they'll feel comfortable, sir. And patient,
then most of the times you have to supplement with mask and back ventilation for a few minutes. If the patient says
will be usually comfortable with up to T4, sir. And the motor, graded curve, if we see the position, then I don't think the patient will be uncomfortable till T4. So instead of checking for like pain, we need to check for this sensory sensation. And cool and normal, gauze to check chestam kada. So that with that if we check and that comes up to T4, patient is also comfortable without any breathing issues and pain issues. So that's what I mean. Correct me if I'm wrong, but that's what I'm
T4 touch sensation is absent until T4. We have to maintain like this is given.
That is given in books, but how many of you us are practicing while
Sir,
giving?
We follow it. We follow it that way only, sir. Here.
Okay. Chaitanya, what is fetal Doppler lo early deceleration, variable deceleration, and late deceleration? What it indicates?
Sir, mali question repeat cheyra.
The importance of early deceleration, variable deceleration, and late deceleration in fetal Doppler.
Maybe it's it tells us the uterine contractions.
ఒకటి హెడ్ కంప్రెషన్, లేట్ డిసెలరేషన్, హెడ్ కంప్రెషన్ అనుకుంటా. ఎఫ్హెచ్ఆర్ వేరియబిలిటీ ఒకటి ఎర్లీ డిసెలరేషన్ ఉంటుంది సార్.
Early deceleration is a fetal compression. Variable and late indicates placental insufficiency or decreased uterine blood flow.
ఎఫ్హెచ్ఆర్ వేరియబిలిటీ ఉంటుందా రెండిట్లోనండి? ఓ ఎర్లీ హెడ్ కంప్రెషన్ సార్. ఓకే.
What is Bishop's score?
Caesarean is definitely most simple and most complicated surgery, sir. Of all.
Most simple surgery that can actually go wrong and create a very difficulty for us.
That is breadwinner of most of the anesthetists. Chandana unte, what is Bishop's score?
చందన అటెండ్ అవ్వలేదు అనుకుంటా సార్.
వాళ్ళు కాన్ఫరెన్స్ కి వెళ్ళారు, డాక్టర్ శేఖర్ అండ్ చందన.
Bishop's score 5 factors ఉంటాయి. Station of the head, consistency, effacement,
dilatation. Yes.
ఆ స్కోర్ మోర్ దాన్ 8 ఎంత ఉంటే డెలివరీ, vaginal delivery spot.
Sir, oxytocin dosing, how do you follow, sir?
ఏంటి క్వశ్చన్ ఏంటి?
Oxytocin, sir.
ఆక్సిటోసిన్ అది చాలా మంది గైనకాలజిస్టులు రకరకాలుగా చెప్తారు. ఫస్ట్ మనం 2 ampules అంటే 10 units.
మళ్ళీ చెప్పండి.
10 units of oxytocin. 1 ampule consists of 5 units. So
10 units initially and then 10 units as infusion, I think.
అదేస్తాము. నెక్స్ట్ బాటిల్ లో కూడా 5 units ఏమంటారు కొంతమంది ఒక యాంపుల్ ఐఎం ఏమంటారు.
యూట్రైన్ అదే సరిగ్గా రాకపోతే
మామూలుగా ఇక్కడ 10 డైరెక్ట్ గా ఇస్తాం సార్ ఇనిషియల్ ఆఫ్టర్ డెలివరీ అండ్ దెన్ 10 units in the bottle whichever is going menace. Sir, how much is amount of drug that you give during spinal anesthesia, sir? Ante I've heard many things. Kontamandi only 0.8 ml istaranta. Kontamandi like how much do you all follow, sir? Srikanth sir, Ramprasad sir.
0.8 ఇచ్చేంత టాలెంట్ లేదు కానీ 1.8 ఇస్తాను జనరల్ గా. ఆల్ బిల్ట్ అయితే 2.2 కెళ్ళిన సందర్భాలు కూడా ఉన్నాయి. బట్ దట్స్ ఎక్స్ట్రీమ్లీ కొంచెం రేర్ గా చాలా హై తో కొంతమంది ఉంటారు. వాళ్ళకి 2.2 చాలా రేర్ గా. ఐ మీన్ లైక్ ఇన్ మై 10 years మోస్ట్లీ 2-3 పేషెంట్స్ కి ఇచ్చి ఉంటాను 2.2. బట్ 1.8 is what I give 90% of time.
1.8 including
నేను 2 cc ఇస్తాను. I usually give 2 cc.
Okay.
I don't add it.
I actually, and we are in PG time, lignocaine is available. So that time we are given 0.8.
Okay.
So later, bupropion came. After that, only changed everything.
Sir, ఈ
Lignocaine
1.8 and 2
0.8
including fentanyl, sir?
Hey, fentanyl and action, no additives,
Okay.
plain. So
It's,
it is concept.
We
Only
used to
about-
give 1.8 plus 0.2 fentanyl. So altogether 2.
yes, ma'am.
That's what we follow. 20 to 25 mics of fentanyl if you want to give it as additive.
The meter says 20 mics of fentanyl should be fine. 20.
Okay.
Actually, I have done 2 studies in caesarean section. That is graded spinal anesthesia. Instead of giving it as a single bolus, we have to wait for 30 seconds, 60 seconds, or 90 seconds. Like 1/3, 2/3 is given initially after 30 seconds, and the remaining after one study after 45 seconds, another study after 60 seconds. So we give, and then we wait for. Immediately after the second dose is given, complete dose, we make the patient lie down. In that case, the dose we can give little 2.2 have given, and because of that, the level is around T6. But none of the patient complained of any that peritoneal pain or anything during the caesarean section. We used 2.2 total because where I did the study, it was a medical college. So most of them are trainees. They will take more than an hour for the surgery. So that is the case. We use 2.2, and both the cases, the Apgar score was very good, and then the hypotension was very less, and even whatever like cardiac complications were very less, and the patients were maintained, and the requirement of vasopressors was also very less. So I think we can do that instead of giving a single bolus dose.
But how do you position? How do you stop in between?
No, yeah, because all the cases we have done in sitting position. So the dense
Sitting position, if you have given some dose and make them sit for that
no,
long,
not
not
like
right.
that. All cases in the sitting position, we give 2/3 of the dose initially. Just wait for 30 seconds more and give the remaining dose. So that the level will not become high, but whatever lower level it is up to T6, it becomes dense anesthesia. And even the post-operative first call for pain is also delayed. And slightly more duration of motor blockade, but that is okay because patients are anyway not moving in the post-operative period.
You give some dose and you hold the syringe like that. So
yes.
they don't leak and you don't push.
Yeah,
So
I just hold everything like that only. Just wait for that few seconds to.
First dose means how much we have to give?
Total is 2.2, no? Out of it, 2/3 is 1.5 ml. Then the remaining after the duration, like 30 seconds or 60 seconds.
Okay. Remaining drug we have to give.
Yeah, the remaining after that, whatever time they have done.
But is anywhere this practice is practiced now?
Yeah, we are. There are so many studies like that.
So is anywhere they are practicing this type even now?
Yeah, I'm practicing for any anesthesia, any spinal anesthesia. I don't give as a single bolus. I just wait.
Okay.
Because in that case, what happens? The level of anesthesia will not go very high. The dense block will be there wherever you are giving, and where you are required, it has to be required.
I practice most of the times in lateral position in caesarean sections. If it is difficult only, I will give in sitting position.
Yeah, sir. But nowadays, even I was also trained like that in the lateral position only. But in everywhere, any place you go, they want only the sitting position only. Even the technicians also make them suddenly sitting position only. That is the reason we have to do this study in sitting position. Everywhere in Hyderabad, everywhere it is sitting position. Even here also, everywhere it is sitting position, because our juniors are trained like that and they want to practice like that only. We cannot change it. Because
It's
I think
because
maybe
in full term pregnant, folding and lying down and folding so much is also difficult, and also with their weight put on and in their condition, like a spinal curvature is also not like otherwise like young fit patients. It's not like that. It changes the curve, so it's difficult to get them in that position. You have to curl them so much. So rather than that,
not
if you sit them up,
required.
just lean forward. Also, you can see the midline clearly. And
Yes.
without so many attempts, you can do it better. That's why even like in other countries, they are doing in sitting. Only like a very senior and the previous generation anesthetists, they are still doing in lateral, but some of them they do epidural spinal in lateral. They also say 25 gauge needle, 26 gauge needle. It's difficult to get spinal that easily. So what they are doing is some of them, they put the epidural needle, it's like a guide. So through that they give spinal. I've seen some of them doing like that.
Madam, mid-spinal, what you said is correct. But I practice paraspinal in lateral position.
Even I can do, sir. I can also do lateral position, because I don't know, we are trained like that. Everything was in lateral position only, unless difficult spinal anesthesia, we used to give in sitting position. And another thing is, in sitting position, like they are making the patient sit on the table with the legs straight. I don't think that is appropriate posture. It should be on the lateral. Patient's legs should be hanging down on the, kept on the stool actually. That is how the curvature is maintained. We can give the appropriate posture for spinal anesthesia.
Hello. Good morning, ma'am. Ma'am, in one of the slides you mentioned about colloid preloading or colloid co-loading. Is it really being practiced now, and does it really reduce the incidence of hypotension in elective cesarean sections?
No, not elective cases. Some rare some cases we can use, not particularly elective cases.
Okay, preloading with colloids.
But I think colloids preloading actually it is removed from, like colloid use only is removed from fluid resuscitation. I think
I've never heard colloids preloading.
Yeah.
Rare cases, not regularly.
And another thing is whenever the cesarean is being done, maybe in an elective or emergency, if the head is already engaged, sometimes the surgeon, we have to see what the surgery is being done and what step they are doing. Sometimes what happens is when the head is already engaged, sometimes they will ask the anesthetist to push the head up. And sometimes even after the baby is delivered, the uterus will not be in the correct position, it will be inverted. So we have to monitor each and every step of the cesarean section during that period. Otherwise, all the blame will come to us only. The uterus then may not contract and the bleeding may continue.
Madam, obviously no gynecologist will take responsibility for anything.
That is what we have to.
Yes. So
we have to monitor.
Totally, they push it on us.
ఎవరైనా ఏ సిటీ సర్జన్ ఒప్పుకుంటారా ఏంటి?
సార్ ఎస్పెషల్లీ
నేను బాగా చేసాను సచ్చినట్టు అందరూ అంతే.
అంటే especially the main points are like unanticipated emergencies are main. High risk obstetrics is a different thing, and already previous and we know that something is wrong and then proceeding for cesarean is different, but normal ga case kan take up chesindi unanticipated blood loss PPH avi manage cheyadaniki ready ga undalu. Main threat ade cesareans lo. సో ఆల్రెడీ అబ్రప్షియా ప్లసెంటా ఏదో ఉంటే ముందు ఆల్రెడీ మనం కన్సెంట్లు అవి తీసుకుంటాం. సో ఎంతో కొంత రిస్క్ ఉందని. అన్ఆంటిసిపేటెడ్ పీపీహెచ్ ఇస్ రియల్ నైట్ మేర్ మనకి.
Srikanth, what is the cutoff platelet level for cesarean section? Spinal.
సార్ సిజేరియన్ కటాఫ్ ఏదైనా మనం చేయాల్సిందే డెఫినెట్ గా. But like it's same for as the guidelines also says the same thing. So in an invasive procedure you have to have 50,000 platelets at least. So if it is less than 50,000 you have to go for platelet cover just immediately before.
Is it not 70,000? 50,000 చాలా తక్కువ. 70,000
I think 80,000, sir. When your LP means 80,000 above, you have to maintain. Major surgery 1 lakh.
1 lakh major surgery 1 lakh, sir. Adi 50,000
patient is posted for cesarean section. Platelet count is 70,000. Can we go for spinal or not?
Sir, the surgery itself carries a risk of bleeding, sir. Spinal lo inke oka sir fine needle ichukoni chesadu. Adi there is always
cut off level ఈ ASRA guidelines ప్రకారం ఎంత?
Sir, it clearly says 50,000 for invasive procedure, 1 lakh for major surgery. So cesarean obviously come as major surgery, I think, because the risk of blood loss మామూలు general hernia hydroceles కంటే cesarean లో ఎక్కువ ఉంటుంది కాబట్టి. So cut off if we think it is 1 lakh, because we rarely wait in that ITP cases, sir. ITP cases లో కొంత వెయిట్ చేస్తాం కదా కొన్ని కేసెస్ లోనే. అంటే if you have that 1 or 2 days time like that. So or else emergency or near term delivery అది ఉంటే ఇంకా చేసేది ఏం లేదు కదా సార్. We have to push for surgery for fetus and కవర్ చేసుకోవడం పెట్టేసుకోవడం అంటే. మెయిన్ కేసెస్ లో ద థ్రెట్ ఈస్ మోర్ దెన్ ద డెలివరీ అండ్ ఆల్. ఫీటల్ అది తర్వాత పీపీహెచ్ రిస్క్ చాలా ఎక్కువ ఉంటుంది సార్. యాక్చువల్గా ఫర్ 2 cases we have faced a lot of trouble. ఇలాగే ఐటీపీ కేసెస్ చేసాము, తర్వాత పీపీహెచ్ కొంచెం డిఫికల్ట్ అయింది మేనేజ్ చేయడం. లక్కీలీ we saved both the patients, but it's like 48 hours of full మంచి థ్రిల్లర్ మూవీ నడిచింది.
Sir, in those unanticipated emergencies that you mentioned, how would you, I mean, what is the ideal time to give opioids, sir, like fentanyl and all, like before delivery, after delivery, and some dose before, some dose after, and how do you like supplement analgesia till then?
After umbilical cord tying or cutting the umbilical cord.
ఫస్ట్ ఆఫ్ ఆల్ దేనికి అడుగుతున్నావు నువ్వు అనాలిసిస్?
Cesarean, sir. For cesarean in those unanticipated emergencies under GA, sir.
Under general anesthesia, okay.
Yeah, under GA, yeah. So ideally,
ఐడియల్ గా ఇఫ్ ఇట్ ఆల్ సూపర్ ఫాస్ట్ సర్జన్స్ అంటే రావణ్ ప్రసాద్ సార్ తెలుసు ఒక సూపర్ ఫాస్ట్ సర్జన్ మహాకుల్ గారు అండి. గాజు ఒక ఆర్కేకి వస్తారు, కరెక్ట్ గా నానా టైం చూసుకోనా అంటారు. ఎగ్జాక్ట్లీ 1.5 to 2 minutes అనమాట ఆయన డెలివరీ టైం. సో ఇన్ దోస్ కేసెస్ జనరల్లీ అంత అంటే మరి 2 minutes కాకపోయినా కొంచెం అంటే ఫాస్ట్ గా చేసే సర్జన్స్ ఉంటే ఐడియల్ గా రిలాక్సెంట్ కూడా వద్దంటారు బిఫోర్ డెలివరీ. బిఫోర్ డెలివరీ జస్ట్ విత్ ఇండక్షన్ అండ్ ఏజెంట్ వీ కెన్ ప్రొసీడ్. అంటే
నైట్రస్ కూడా పెట్టద్దంటారు. Till delivery of the baby, don't give nitrous.
Till delivery of the patient, baby. But అంత ఫాస్ట్ ప్లసెంటల్ ట్రాన్స్ఫర్ ఉంటుందా మజిల్ రిలాక్సెంట్ కానీ నాకు కూడా చిన్న డౌట్ ఉంది డెఫినెట్ గా. అండ్ దెర్ ఆర్ కన్ఫ్లిక్టింగ్ స్టడీస్ రిగార్డింగ్ ప్లసెంటల్ ట్రాన్స్ఫర్. సో అంత ఫాస్ట్ గా ఎంత టైం పడుతుంది జనరల్ గా అని మనం ఇచ్చిన ఐవి డ్రగ్ కి టు యాక్ట్ ఆన్ ఫీటస్. బట్ జనరలీ దే సే if fast surgery is there we can avoid. బట్ మన సునీత మేడం లా సాయిబాబా అనుకుంటూ మెల్కే చేస్తే we have to give relaxant, లేదంటే అక్కడ అవ్వదు అసలు. So that's what. But
Because I used to give always 25 mics before incision I used to give, sir. ఆ తర్వాత అయిపోయాక బేబీ డెలివరీ అయిపోయాక అప్పుడు మిగిలింది ఇచ్చేవాడిని అనమాట. అంటే ఎవ్రీ టైమ్ ఇట్ యూస్ టు వర్క్ ఓకే.
ఇప్పుడు లైక్ చెప్తాను చూడు, ఇది చాలా చాలా మందికి అండ్ అఫ్ కోర్స్ చాలా మన థియరీలో కూడా చాలా బర్డ్స్ ఏ వ్యూ ఉంటది. ఇప్పుడు we see only the effect of the drugs on fetus like that. So if you don't give preemptive analgesia, so the pressure response of intubation and pressure response of the surgical incision and all those also carry. So if there is maternal tachycardia, then also fetal compromise will be there. So we think of only drugs. That is why the conflicting reports are there. But we have to anesthesia is itself a balancing act, and we have to see and proceed.
Like for emergency GAs, we used to give like a rapid sequence with succinylcholine and 1 mic of fentanyl, 1 mic per kg fentanyl we used to give, and as soon as the baby is delivered, we used to give opioid. There they give morphine also. So we used to give fentanyl or morphine or whatever you want opioid. We used to give the other opioids like other than fentanyl after the delivery of the baby. Like initially rapid sequence succinylcholine, but as the baby is delivering, they may come out, mom may come out of succinylcholine. So we used to give other relaxant. There's no problem. We used to give mostly used to give atracurium.
Okay.
Some of my teachers used to practice emptying the stomach with rice tube before induction in pregnancy, caesarean section.
Yeah, but you should not keep rice tube during rapid sequence induction. It itself hampers the proper procedure of Selix maneuver, right?
Yes,
so
yes. Empty the stomach and remove the rice tube.
Okay. But usually there they used to give like sodium citrate, metoclopramide, all these but if it's real emergency, they used to shift the patient to delivery, I mean like theater from delivery suite. Within 2-3 minutes they used to rush them, and you don't even have any quick spinal also. They never used to allow if it's that emergency. If they think fetal heart is not good, so go straight into theater. They just get sodium citrate before rushing them to theater, and you do rapid sequence. That's a real emergency. Baby used to be out within 10 minutes of giving a emergency call.
For the sake of students, who is Apgar? Ravi Leda, Ravi. Apgar is a female anesthetist.
Never even thought of that. Thank you.
Hello? Huh?
And actually, because discussion also has DNP students, see, whatever we follow practically is different, but whatever we have in the books is different. But for the exam purpose, always go by the books, always follow the books. And practically really, I mean, theoretically correct avvachu, but always go by the books. And according to the books and ASRA guidelines, less than 80,000 is contraindication for your epidural or spinal, and less than 40,000 is a contraindication for lumbar puncture. So we'll follow that according to the ASRA guidelines, Adil.
Thank you, ma'am.
Recently, we got one patient from outside hospital, immediate post cesarean, a few hours after cesarean, sending to us saying that the patient is dropping blood pressure and oozing a lot from the incision site. So they blood pressure was below 80 when the patient came to us. So as soon as patient came, even before patient came, did speak to the doctor who did the cesarean. I asked what was the anesthesia, what were the numbers, what was the HP and platelets, all these coagulation profile. She said nothing was done. I said, what about platelets? She said, no, it's elective cesarean, so we didn't do anything. And what was the condition, antenatal checkups and any high blood pressure, anything? She said, only during cesarean, for cesarean they came. So that time little bit high. So we thought it's anxious and they were very anxious and panic. So BP shot up. In India, people don't go for proper antenatal checkups. So probably she had preeclampsia, which nobody even tested, neither urine proteins nor platelets nor coagulopathy, nothing was done. So when she came, when we did test, liver enzymes were elevated and platelets were 30,000. So that was the case. So, but how can we say this is a condition of patient? So that's why she bled. The relatives will go and argue or fight at that hospital. So we had to say patient dropped platelets, that's why bleeding. This problem can occur anytime like that. We had to cover them. So, but anywhere in peripheries, even if it is an elective cesarean, have to do at least CBC platelets. Or if you suspect a high blood pressure, don't take it for granted because they're anxious or panic. Try and do other things like LFTs, coagulation tests. But she had to stay in ICU for 4-5 days, then shifted to room. So that's all extra cost, right? Poor people. Particularly people who do in peripheries have to take at least few simple tests and do the cesareans.
Anuradha madam, do you have any experience of COVID positive cesareans?
COVID positive cesarean. No, sir.
Even I don't have. Anybody has done in this
సార్
group?
కేజెస్ చేయలేదా?
నేను రిటైర్ అయిపోయాను కదా.
అప్పుడు నాకు తెలిసి మెడికవర్, అపోలో, కేజీహెచ్ చేసినట్టున్నారు సార్.
అపోలోలో చేశారండి నాకు తెలిసి, బట్ దే చార్జ్ ఎ లాట్. మా దగ్గరకు వచ్చారు కానీ వి వర్ నాట్ టేకింగ్ కోవిడ్ కేసెస్. సో ఎక్కడ చేస్తున్నారు కనుక్కుని పంపించేసాము.
అప్పుడు జిఏ ఇచ్చారా మేడం స్పైన్లా?
Whatever is required, ante if they are okay, they preferred neuraxial block only. Why GA andi? Unless there is indication, GA ever ivvaledu. Okay. And you try to avoid GA kada COVID patient ki.
COVID sir.
Good morning, madam. Good morning, sir. Sir, myself, Dr. Mahesh, sir. We did the cases at Ashram Medical College, sir. COVID cesareans under spinal only, sir. Most of the cases under spinal only. At the time with the precautions, PPE kit like this, sir.
If the platelet count was low, then you have to go for GA. Huh? COVID sometimes
Yes,
platelets count drops.
Yes, sir. At that time, my assistant did the GA case only, GA cases, sir. But we PGs at that time, we did only spinal only, sir.
Okay. What
Under
was the
spinal,
outcome?
sir.
Outcome was good.
Outcome is good only, sir. All the cases good only. GA mostly 2 cases only. Our residents go ahead with GA, sir. Mostly we gave spinal only, sir. We did the cases under spinal only, sir.
How was the newborn Abgar score in the? Okay.
Yeah. Newborn outcome is fine only, sir.
Okay.
Yeah.
Shrika,
Madam,
any questions from Raja?
లేరు అనుకోండి కిరణ్ అవుట్ ఆఫ్ స్టేషన్ లో ఉన్నట్టున్నాను.
Maybe
కజిరంగా
conference.
మంచి ఫోటోలు పెట్టాడు.
Okay. Maybe conference. Okay.
ఇంకా అదే షిల్లాంగ్ వెళ్ళారు మేడం అటు నుంచి అలాగా నేషనల్ కాన్ఫరెన్స్.
Maybe Shillong, Dr. Shekhar Chandana gone to national conference Shillong only.
ఓకే ఓకే.
Thank you, Anuradha.